Hello, everyone, and welcome to St. John's Institute Be Inspired Speaker Series. Today's topic is expanding the impact for early stage prostate cancer treatments and active surveillance. My name is Mary Burns, and I'm a development director at St. John's Health Center Foundation. As of January 2021, the John Wayne Cancer Institute changed its name to St. John's Cancer Institute. This change is in name only and will not impact the Institute's operations in any way. St. John's Cancer Institute remains committed to providing excellence in research, education, and cancer care through clinical trials, immunotherapy, genomics, and precision medicine. Our fellowship program will now be called the Donald L. Morton, MD, Complex General Surgical Oncology Fellowship Program, named after Dr. Morton, who founded the Institute. Before we start our discussion, as you will notice, everyone but the presenters are muted so that you will all be able to hear them well. I want to encourage you to ask questions by using the chat feature on your computer screen. The chat feature looks like a thought bubble and is found at the bottom of your screen. Throughout the discussion, we will be able to read your question, and our moderator, Dr. Martin, will ask a panelist to answer. If we're unable to answer your question during the webinar, we will follow up with you in an email. And should you have any further questions after the webinar, please email us and we'll be happy to reply. We have a very exciting and most interesting hour ahead of us as we will hear from St. John's Health Center physician experts in the areas of urology, urologic oncology, as well as radiation and medical oncology. I'm delighted to introduce our distinguished panel of physicians. Our first panelist is Dr. Jennifer Linehan. Dr. Linehan is a board-certified urologist and an associate professor of urology and urologic oncology at the St. John's Cancer Institute. Dr. Linehan completed her medical degree at the College of Medicine at the University of Arizona and was fellowship trained at the City of Hope in urologic oncology and robotic surgery. Dr. Linehan's expertise and interests are minimally invasive approaches to urologic oncology and reconstructive urology, with a particular emphasis on robotic-assisted procedures. She also practices general urology and in her research has worked closely on helping to identify biomarkers for prostate cancer. To be just a little more personal, I'm going to ask each doctor a question. Dr. Linehan, why did you choose urologic oncology as your specialty?
I think when I was a medical student, I was a second year medical student when I decided I wanted to go into urology. And I really fell in love with both the surgical and medical perspective of urology because there's a lot of surgery for prostate cancer, for bladder cancer, for kidney cancer, and that's very interesting. But I thought there was a lot of medical care that we could offer patients to help them, even within the office, not having to do surgery. And I really liked both sides of the coin.
Great answer. Thank you. Our next panelist is Dr. Przemyslaw Twardowski. And Dr. Twardowski, or Dr. T, as we call him, is a medical oncologist and the director of clinical research in urology and urologic cancer at St. John's Cancer Institute and Cancer Clinic. Dr. T completed his medical degree from the University of Missouri Columbia School of Medicine and is fellowship trained at McGaw Medical Center of Northwestern University in both hematology and hematology oncology. Dr. T's expertise and interests are the management of urinary tract malignancies, including prostate, bladder, kidney, and testicular cancers. Over the last 20 years, he has been a principal investigator and contributor to multiple clinical trials that have successfully expanded treatment options for patients with cancers of genitourinary tract. Dr. T, what are you most hopeful for your patients?
Mary, thanks for this kind introduction. So I think we're all in the field where we are hopeful for better and longer life of our patients, and obviously ultimately cures. I mean, that's I think what we went to the field, and I think we're slowly but surely getting in that direction. And that's keeps us going and motivated to take care of our patients and do innovative research going forward.
You have lucky patients. Thank you, Dr. Twardowski. Our third panelist is Dr. Tim Wilson, who's board certified urologist who specializes and has vast experience with minimally invasive laparoscopic and robotic assisted urologic oncology. In terms of volume, he is one of the top 6 surgeons in the world performing robotic assisted laparoscopic prostatectomy. Dr. Wilson completed his medical degree from Oregon Health and Science University School of Medicine and is fellowship trained at the City of Hope in urology. Throughout his tenure, which spans nearly 37 years, he has published numerous peer-reviewed articles and book chapters in areas of urologic, oncology, urinary reconstruction, and robotic surgery. Dr. Wilson, what excites you about robotic-assisted surgery?
Well, thank you, Mary, for that introduction. And I want to welcome everyone that's attending the webinar today. We're happy to meet you and give you some more information about prostate cancer. But Mary, in regards to your question, robotic surgery was a game changer for me and my associates when we were at City of Hope many years ago. And we were one of the early adopters of robotic surgery in as early as 2003. And so it was a game changer for me in terms of my career, because the US we were the earliest in the world to start robotic surgery. It enabled us to travel around the world for teaching and learning from others in Europe and Asia and other countries. In terms of prostate cancer specifically and prostatectomy, removing the prostate during surgery, robotic surgery was allowed for a more consistent, reliable, and reproducible operation. It took an operation that used to be really varied in terms of outcomes, and it squeezed it down so that regardless of men's age, the size of the prostate, it allows for a more consistent surgery that can be done in a very reliable and safe way.
Wonderful. Well, thank you very much, Dr. Wilson. And our fourth panelist is Dr. Robert Wollman. He is a board certified radiation oncologist and is the medical director of radiation oncology at St. John's Health Center. Dr. Wollman completed his medical degree from New York University School of Medicine with over 32 years of experience. And his areas of expertise include prostate, bladder, lung, breast, brain, head and neck, skin cancer, partial breast irradiation, stereotactic radiosurgery, radiotherapy, and image-guided intensity modulated radiation therapy. Boy, you're busy. Dr. Wollman, what are some of the most rewarding aspects of what you do for patients?
Well, thanks a lot for the introduction and for inviting all of us today. Most rewarding is to cure cancer and to alleviate the symptoms of cancer. And when we can do that effectively, reliably, and as part of a team with the patient, with all of the colleagues that you see assembled today, that gives enormous satisfaction. And seeing patients year after year that I've treated in the past that are now cured of cancer is, there's nothing that beats that.
I can only imagine for the patient and their families. Thank you, Dr. Wollman. Moderating today is Dr. Neil Martin. He's the interim executive director of the St. John's Cancer Institute. Dr. Martin is a neurosurgeon and is also the regional medical director of neuroscience for Providence, Southern California, overseeing neurosciences for Providence hospitals and clinics across all of Southern California. Without further ado, take it away, Dr. Martin.
Mary, thank you so much for those kind introductions. It's a great pleasure. It's a privilege to be on a panel with so many experts. And, prostate cancer is an area where perhaps we have more management options than in almost any other disorder I can think of. And so clinicians and patients have many questions about how to select from the various different options, which range from from observation, no invasive treatment whatsoever, because some cancers are very slow growing, to radiation therapy of multiple different types, to different options for chemotherapy, and for several surgical options. And so we've got experts in every one of these fields. And I'm going to start off by asking a couple of questions. For Dr. Linehan, when a patient has a positive PSA, what's the next step?
So it depends on what you mean by a positive PSA. So I think for urologists, and for probably most of us on this call too, it's the trend in the PSA that's really more important for each patient than the actual number itself. So, I mean, I have patients that have PSAs that are as high as 22, that have had multiple biopsies or do not have prostate cancer, but that's what their PSA has been most of their life. And I also have patients that have had prostate cancer with a PSA of 2. So I think it's really about the trend for me and not about the number. But if I am suspicious that the trend is changing or that it looks like the PSA is rising conspicuously, then I think one of the first things that you can do is consider a test like a 4K test, which can help you risk stratify the patient. And that's a blood test that we use in addition to the PSA. Or the other thing you can do is get an MRI of the prostate to see if there's any lesions in the prostate.
So, Dr. T, if there's a strong suspicion that one of those tests indicates that the patient has prostate cancer, how do you determine unequivocally that they have prostate cancer, and assess whether or not it's a rapidly growing tumor that's dangerous, or one that's likely to be very indolent and may never really cause a clinical problem?
Yeah, so once we have enough of a suspicion and concern, it's really primarily falls into our urology colleagues, so either Dr. Linehan and Wilson, to help us with performing the biopsy. And despite all these advances with imaging like MRI, some fancy sophisticated blood tests, the ultimate proof of diagnosis of prostate cancer relies still on biopsy, which is essentially sampling of the prostate. We do it sometimes in a sophisticated way that Dr. Linehan and Wilson can probably describe better, using kind of real life imaging based on fusion of MRI pictures and ultrasound for guidance where the needle should go, just to maximize the yield. And then the pathology is a field specializing in interpretation of the biopsy results under microscope. And that provides really the key information. If the diagnosis of prostate cancer is indeed confirmed under microscope, there is a certain grading of prostate cancer that determines the significance. And that relies on some characteristics of cancer cells and the position of the cells, whether they form glands or not, that assigns a certain grade. And that tells us whether the cancer is significant, if it needs to be treated, or perhaps, which may be a subject of further comments here, whether it could be just observed for a period of time.
Right. What's the role of genetic testing or molecular diagnostics in understanding better the outlook for a particular patient with prostate cancer?
If you're directing it to me, Neil, yeah, I mean, I think I would be interested to hear what my esteemed colleagues on the panel think about it. But there are certainly some genetic tests or genomic tests that look at expression of genes in the prostate cancer biopsy specimen, that the certain patterns of gene characteristics and expression may stratify patients better in terms of the risk. So that may provide, it may not be a decisive factor outside of kind of more routine visual characterization of the cancer cells, but it may sometimes sway us one way or the other whether the cancer is aggressive or not. So it has some role, I would say not decisive role. The only other comment I would make that we're also learning more that there are certain inherited characteristics or inherited mutations that can be associated with the risk of prostate cancer. For example, the gene called BRCA. So if there is a strong family history of prostate cancer, breast, ovarian cancer, it may be worthwhile to do that blood test for inherited susceptibility. And those prostate cancers that are linked to that kind of genetic background, they are associated with worse prognosis in general. So they would usually be treated more aggressively, despite, regardless of how they look under microscope, they would be considered higher risk. So those are not common mutations, but we are thinking about them more and more and testing for them quite a lot these days.
Dr. Wilson, so the initial evaluation suggests there may be prostate cancer, and I'm assuming that in many or all of these cases, a biopsy is indicated. As a surgeon, how is the biopsy done? Is this an outpatient procedure? Is this require admission? How is it done from the surgical perspective?
Right. Thank you, Dr. Martin. So the first thing, as that's been alluded to, is that once we determine that someone's at high risk for prostate cancer based on the PSA and maybe some other testing, then, or perhaps the digital examination of the prostate, the physical examination shows a nodule that we think is suspicious, then these days we will typically get an MRI of the prostate. And MRIs have come along, they've been around for a long time for prostate cancer, but it's only been within the last 5 to 7 years that the technology has advanced enough so that we can better see prostate cancer on an MRI and the extent of it. So we'll typically get the MRI first. And if that shows an abnormality on the prostate that's suspicious for prostate cancer, then we have special technology. We're blessed here at St. John's because we have really advanced technology that allows us to perform what's called digital fusion, where under real time, we can merge an ultrasound image that we're doing of the prostate at that time on the patient when he's having the biopsy. We're able to digitally fuse with the software package that's available called DynaCAD to fuse the ultrasound with the MRI and to specifically see the target on the MRI, match the two images together, and specifically biopsy or sample that spot. Now, it does turn out that biopsies aren't, MRIs aren't perfect, and so they can miss some high-risk prostate cancers. So we still biopsy or sample the rest of the prostate as well. So, and then just in terms of how the procedure goes, so it's usually done under a local anesthetic, maybe with some mild sedation. The patient lays on their left side, kind of in the knee chest position. We pre-treat them with some antibiotics to prevent infection. We then examine the prostate with the finger, and then we put an ultrasound probe in the rectum to see the prostate. As I say, we use then this technology to merge the two images, to fuse the images, and we take little tiny samples of the gland, little tiny cores of tissue, and then those are sent to pathology for review. And as Dr. Twardowski said, then those are examined, number one, to see if there is prostate cancer there, and then it's very important to characterize that in terms of the grading. How, in other words, how aggressive the cancer is. The grading system we use for prostate cancer is referred to as the Gleason's grading and scoring system. And then based on that, it helps us determine, number one, if men need treatment and what kind of treatment might be best. I think that does it for the most part, but usually it's done under local anesthesia, not terribly painful. It takes about 15 minutes to do. Sometimes we do it under kind of a twilight sleep, like you would have if you were having a colonoscopy. On some occasions, we do a biopsy through the skin underneath the scrotum, through the perineum, in special cases. So, but that and although that may sound bad and painful, it's not, and it's a safe and effective way to biopsy the prostate in certain areas if the MRI shows certain lesions more towards the top of the prostate.
Okay, great. And people generally go home after the procedure after
Yes.
an hour or two.
Not even that. So men will leave the clinic if we do it under a local anesthetic within usually 15, 20 minutes of the biopsy. Side effects are minimal. There could be a little bit of blood in the stool and the urine, both which will last for a couple of days. There can be some blood in the semen that'll go on for 3 to 5 weeks, but and infection rates are extremely low.
And so you've done that, the biopsy comes back. And I guess the next step is the patient comes to you and talks to you as the surgeon about options, about the findings and the options. What's the next step in this journey?
Right. So this is a good question for Dr. Wollman as well. But so once the gentleman's diagnosed with prostate cancer, depending on what his PSA was, depending on the characteristics of the prostate, and a few other things, we may get some additional imaging like CT scan, bone scan. There's some newer scans, like newer PET scans that are now available that have just been approved, what's called a PSMA scan. So again, depending on the PSA, depending on the characteristics of the cancer, the Gleason's rating or grading and scoring system, some of those scanning may be done to make sure the cancer is confined to the prostate or to fully evaluate its full extent. And then based on that, if it's confined to the prostate, then again, depending on the characteristics, if it's low grade and extremely slow growing, we know that it's perfectly safe to monitor those men. And we will monitor them with periodic PSAs, anywhere from 3 to 6 months. And then repeat an MRI typically once a year with periodic biopsies if the PSA and the MRI change. Generally speaking, if the cancer is somewhat more aggressive but still confined to the prostate, then surgery is an option. And so patients will speak with me and or Dr. Linehan about that as urologic cancer surgeons. And they'll also meet with a radiation oncologist like Dr. Wollman to discuss different options of treatment with radiation options.
Yeah. Okay, thanks.
Sure.
Dr. Wollman, what's the nature of that discussion that you normally would have with a patient with cancer confined to the prostate?
That's a really interesting and great question. When we think about somebody just diagnosed with prostate cancer, we've already talked about that they have the option sometimes of keeping an eye on it for a while. They have the option of doing surgery sometimes, the option of doing radiation. There are a couple of other treatments that we haven't even touched on, like cryotherapy, like high frequency ultrasound therapy. And the patients often, but not always, have this long list of things that they potentially could do or not do. And we need to sort of help them through that list. And I think a lot of patients come to me and expecting, having read radiation doctors always recommend radiation, or surgery doctors always recommend surgery. And I don't see that as my role when I'm first talking to somebody diagnosed with prostate cancer. I see my role as to try and help them get less confused. So I always promise them when they first come to me, I will not get them unconfused, but I will have them confused at a higher level when they walk out of my office, that they will sometimes understand that one treatment may definitely be off the table. They may not be right for radiation, for example, if they have such bad urinary symptoms that to radiate them would make their urinary frequency and getting up at night so much worse that they'd be so miserable. Some patients are immediately ruled out from a type of radiation if they had radiation before. So you try and narrow down the options, and then you try and help them sort through all the options that are on the table. And that can involve a very, very long discussion based on their goals, their symptoms, their preferences. And we spend a long, long time trying to sort through all that so someone can find out what's right for them as opposed to what's right, if that makes sense.
That does. So there are multiple different options for radiation therapy listed here. What's the primary modality, the primary technique that's used for patients?
Probably the most widely and primary used technique is something called external beam radiation. That's when people come into the radiation department, lie on a table, and we use a machine called a linear accelerator, which is basically it's a very high energy emitter of waves that are like light waves, but more powerful than light waves. And we shoot the radiation into the prostate or into the regional lymph nodes that surround the prostate along with the prostate to kill the cancer. So that's called external beam radiation. There's about 5 different types of external beam radiation. There's something called IMRT. There's something called SBRT. There's a couple of others, cyberknife, gamma knife. You hear a lot of different types of radiation technology, but all those external beam radiations use the energy of the sun, essentially light, to kill the cancer within the prostate without damaging normal tissue. The second most common form of radiation is implantable radiation, which is also called brachytherapy or seed implants, where instead of having a machine shoot the radiation from the outside in, we place radioactive materials inside the prostate and they'll kill the cancer from the inside out. Those are the 2 most common types. And sometimes we combine them.
Okay.
So, Dr. Martin, I just might add, I think that Dr. Wollman hit it on the head when he said, talked about, confusion and all these different options. It's hard for patients to figure out exactly what the right treatment is for them. And so our job really is to try to sort out, what makes sense for each patient based on the information we've gathered, the characteristics of the cancer. PSA is a factor, their age and health is a big factor, and their symptoms, how they urination, a variety of things. What previous maybe treatments, or if they've had previous radiation for something else, is also a factor. And so I think what we try to do is tailor the treatment to the individual to make sure that they're getting the right treatment that's going to be most effective and hopefully minimize the risk of complications down the road.
Right. That sounds reasonable. Dr. Linehan, when a patient could ask you, why would I just watch a cancerous tumor instead of treating it immediately?
Yeah, I think for some patients, this is very hard concept because, for such a long time, when someone has cancer, it's very high pressure, it's very high stress, and we want to do something right away. But I think the last, 50, 60 years of research that we've done on prostate cancer has shown us that patients with low-grade prostate cancers are very indolent, meaning they're not going to metastasize, they're not likely to spread, and they're certainly not likely to cause you death. And the cancer-specific survival in these patients that have low-grade prostate cancer is actually the same as when you treat them. So when we started to look at that over the last probably 15 years, we decided that those patients really did not need to be treated, they needed to be watched. And there's a very specific criteria that you have to have as a patient that will qualify you. These are NCCN guidelines and AUA guidelines that we've worked on that will qualify you as low grade. But our goal is, the preservation of your quality of life as well as your quantity of life. And I think that is really the balance that we all try to find in prostate cancer. And if you're watching prostate cancer closely enough, it tends to be one of the more slower growing cancers. So as long as the patient's not going unmonitored for months or years, you would be able to treat it before it became aggressive.
Okay. So watching it, what does watching it mean? Dr. Wilson alluded to that, but what would you tell a patient?
So watching it usually means getting a PSA, a blood test every 3 to 6 months. Mm-hmm. You need to have, if you have a prostate biopsy that shows that you have low-grade prostate cancer, you need a biopsy 6 months after that, and then after that, another 16 months. So we watch it by checking your blood levels, following it with biopsies, to make sure that when we do the other biopsy, it's not getting more aggressive. And then, you know, basically at least checking in with your urologist once a year, as well as monitoring your labs.
How often does a biopsy result in a serious complication?
The biopsy, so there's only one real serious complication that I worry with a prostate biopsy, which is sepsis or a prostate infection. And those cases, because of the antibiotics that we give now and the way we monitor patients, happens less than 15% of the time. And we usually give patients antibiotics before the biopsy, during the biopsy, and then after the biopsy to take. And I always tell my patients, you know, you're going to have blood in your urine. All those things are very normal, but if you get really bad fevers and chills, come right to the emergency room, because that's the biggest, you know, risk factor.
Okay. So Dr. T, if a patient says, you know, I want to stay away from radiation or surgery, are there any medical options for me with a indolent, slow growing, low grade prostate tumor?
I would say that there are no great options that are commercially or FDA approved in terms of drug therapy for these kind of low grade indolent cancers. So you know, those are handled as Dr. Linehan mentioned with that surveillance option. And so far there hasn't been any data indicating that drug treatments like hormonal therapy or chemotherapy or immune therapy is beneficial in that setting. Now, on the other hand, I would have to say that that active surveillance strategy, as attractive as it is, it's in many cases kind of a delaying strategy. So these patients can be sometimes fine for years, but you know, correct me if I'm wrong, Tim and Jennifer, but roughly maybe 50% of these patients over 5 to 7 years or so will eventually require treatment. So yes, it's good that they have delayed in treatment, but it would be nice certainly to have some sort of intervention that would further delay the need for treatment. So that's when some of these interesting, innovative experimental therapies may come in, clinical trials looking for some novel interventions. And in our institution right now, we are testing the product derived from mushroom, which we have some data from prior studies that it may have some biological effect. And we have clinical trial looking at that, whether patients who are placed on that particular supplement may actually have some benefit in delaying even further the need for treatment. We also participated in the clinical trial recently with an immune kind of vaccine type product that also is looking for that. So very interesting area of investigation, but I would say no current data for any definitive drug therapy in this kind of low grade setting.
Great, that's very useful.
The
The mushroom therapy is quite intriguing. Mushrooms, I guess, ramp up your immune system. Is that right?
That's been always hypothesized, and interestingly, when you really look at the literature, there is a very significant lack of really kind of hard data for that. So we are hoping that with this kind of studies that we're conducting here, we'll answer it in much more definitive fashion. And we obviously have a very, very strong legacy tradition here at the Institute of Immunotherapy. So kind of the understanding of how immune system interacts with cancer is one of the areas of our strengths. So we will want to hopefully leverage that to look very carefully in the specimens from these patients who are on protocol to really learn a lot, hopefully help them, but also learn a lot about the immune system and how it reacts to the mushroom supplement therapy.
Yeah, thanks. Go ahead, Tim.
I just wanted to point out that, I think what's really important is that, prostate cancer still is the leading cause of cancer in men in the United States and the second leading cause of cancer death. And so it's not a cancer that can be ignored. And I think although there are constraints or recommendations regarding screening through shared decision-making with the patient and the urologist and the primary care physician, PSA should be done, probably once a year on all men above the age of 50. Although we may not intervene or do anything about that PSA. So, and then once men are diagnosed with prostate cancer, if they have low risk disease, that we can't forget about that either. As Dr. Linehan and Dr. Twardowski pointed out, many of those men will progress and subsequently need treatment. So it's important to stay on top of it and stay connected with your urologist typically in that situation.
So let me follow that with Dr. Wilson with a question about the surgery. You know, as one of the leaders and very early adopters of minimally invasive robotic surgery for prostate removal, when would you recommend that? What would be the typical patient for whom you would recommend that kind of treatment?
Well, so that's a great question, Dr. Martin. So so generally speaking, it's a healthy gentleman with that's in good condition with good life expectancy. Because we know that prostate cancer is slow growing. Even if we didn't do surgery in most men, it would probably take 7 to 10 years for the cancer to lead to their death. And so we want to be conscious of how healthy they are and how well they would tolerate the anesthesia. The operation itself is about a 3-hour surgery, and physical recovery probably takes in the neighborhood of about 4 to 6 weeks. So anyone that has a cancer that we think has the propensity to spread based on the characteristics like the Gleason score, MRI findings, PSA is a factor. If we think that cancer has a propensity to spread outside the prostate and spread to other organs or like the bone or the lymph node within a reasonable period of time, let's say 3 to 5 years, and we would recommend definitive treatment. And surgery is appropriate for men that have organ confined prostate cancer, even locally advanced prostate cancer, in an effort to fully understand a better look at the characteristics, to better understand the full extent of the cancer, to better stage it, to know exactly what we're dealing with. We can also do genetics testing on the prostate tissue once it's out to understand if they might need additional therapy. And furthermore, once the prostate's out, the PSA becomes an extremely reliable test in terms of monitoring them. Obviously, because PSA only comes from the prostate, once the prostate's removed, the PSA should be 0. And so if it's not 0 and it's subsequently rising, that typically will indicate that there were some prostate cells outside of the prostate that are now growing and making PSA. And so we can detect early recurrence of cancer in men with after surgery by monitoring PSA. Not all those men require treatment. Some of them do. And they might then go on to get radiation to the area to kind of mop up any rogue cells that were outside the prostate. Sometimes we just monitor those men. Also, hormone therapy can be used, and we also the same trial, the mushroom trial that Dr. Twardowski alluded to. We have that'll be able for some men. If their PSA were to pop up after a prostatectomy.
Okay, thank you.
Sure.
Dr. Linehan, I've heard about HIFU treatment for prostate cancer. What exactly is that? How's it done? What does it? How does it eliminate cancer cells?
So HIFU basically stands for high intensity focused ultrasound. And the treatment is done similar to how we do the biopsy. And we actually use a probe that sort of goes up the rectum, up the bottom of the patient. And the probe focuses an ultrasound beam onto the tissue, both at higher energy. And when you focus that energy, it becomes higher intensity. And this does a couple of things. One, it heats up the tissue to usually about over 80 degrees Celsius. 2, it causes the water within the tissue to form gas bubbles that burst. And when that ruptures, that sort of ruptures the cell. And then it causes tissue coagulation is what we call it. And then, if you go back and biopsy the patient like 3-4 months later, you'll find fibrosis or scarring of the lesion that was treated. And it's one of the newer treatments that's come out for prostate cancer. Actually, the Europeans and the Asians were using it, back in 1996. And probably about 2006 or maybe 2008, it started becoming more popular in the United States, and we've been gathering research on it since.
Is that an outpatient procedure?
This is an outpatient procedure. We do it in our outpatient surgery center. The patient will usually have a Foley catheter in for about 7 days after the procedure. And overall, it's tolerated pretty well. There's no incisions, there's no cuts that are made. It's all done, like the biopsy transrectal.
Mhm. And what's the long-term effectiveness of that in preventing regrowth of cancer compared to prostate removal, prostatectomy, surgical prostatectomy?
So right now, like I said, we only have about 8 to 12 years of good data on HIFU. And I tell my patients, you have to look at it in whole gland, whether you're treating the entire prostate versus doing focal therapy. And then you have to understand whether you're treating what grade lesion you're treating on the prostate, whether you're treating patients with intermediate risk prostate cancer or low risk prostate cancer. If you look at the data for patients who got whole gland treatment, it definitely has less side effects as far as impotence and erectile dysfunction than both surgery and radiation. But patients that got HIFU were much more likely to need a secondary treatment, either another HIFU or radiation or cryo after their first treatment. And that was about 60% of those patients that were for whole gland therapy. A lot of our whole gland data is again from Europe. Then we have studies that are on focal therapy, meaning the radiologist sees a lesion on an MRI, and then we use that MRI to focus the ultrasound beam on that specific lesion. And one of the reasons that actually HIFU has gotten better over the last 10 years is our MRI technology got better and our machines for HIFU got better. And now we have a machine called the Focal One that will basically take your MRI image, take the input of data from the real-time ultrasound that I'm doing, and then help the machine find where that lesion is exactly. And then I can give the machine coordinates like, don't go within 4 millimeters of the urethra, don't go within 5 millimeters of the nerve. And then I can plan that out, and then the machine delivers the technology, or it delivers the heat in a sense. And if you look at the data for focal therapy, which is really what you want to try to use something like HIFU for, if you look at the studies of all comers, of patients with low grade, intermediate, or high grade, okay, and that's about 80% of those patients will not need a secondary treatment, which is pretty good.
Mhm.
So if I'd have to break it down for you by sort of the risk to give you what each of the different categories are, but if you just wanted to look at all comers, and I think that's actually a pretty good number. So
How long does the procedure take?
procedure takes about 2 hours.
Okay. All right. Sounds like an interesting advance, and I'm sure it will find its appropriate role within this armamentarium that we have to treat prostate cancer. So Dr. Wollman, what does the ideal patient for radiation therapy look like? What would be the patient where radiation therapy is pretty clearly the right way to go?
There are just so many different types of radiation. It's hard to think of a type of prostate cancer patient that wouldn't benefit from radiation therapy, to be honest with you. Very early stage prostate cancer, not patients who are not being actively undergoing active surveillance, but patients who are very good for, who need a treatment, aren't doing active surveillance. We can often treat them, as long as they've never had previous radiation, that would rule them out from radiation, with just a radioactive seed implant, like I talked about before, which is a 1 hour outpatient procedure where we place seeds. Patients who are good candidates for that have very little what we call obstructive urinary symptoms. So they don't have signs and symptoms of benign prostatic hypertrophy or BPH, which would preclude them getting a good radioactive seed implant because there's a little swelling of the prostate, and that could make their BPH a lot worse. So somebody's a really good candidate for a seed implant, has low-grade prostate cancer, their MRI doesn't show any signs of extracapsular extension, and they have very little lower urinary tract obstructive symptoms. Patients who are good candidates for SBRT, which is highly focused 5 treatment radiation. So it's done in just a week and a half. 10 minutes a day on the radiation table every other day for 5 treatments are similar group of patients to those who are good for a radioactive seed implant. That means they don't have any of the higher intermediate risk features like very high PSA or very high Gleason score. And then patients who are good candidates for IMRT, which is a longer course of radiation often given with hormonal therapy, which is also called androgen deprivation therapy, are patients more in the intermediate risk group. And then patients with really advanced prostate cancer and sometimes even metastatic prostate cancer, they're often treated with the hormonal therapy I just mentioned, plus radiation therapy to the prostate and the lymph nodes. So it's hard to answer your question the way you asked it because it fits into almost any category of patient that needs treatment. It's just that we choose different types of radiation based on that patient's individual prognostic features like their Gleason score, their PSA, and their symptoms that they walk in with.
Okay. Good to know that we have so many options. Dr. T, if a patient has high-grade or invasive prostate cancer that has extended outside of the prostate, what are their options?
Yeah, so that's really kind of on the different end of the spectrum.
Yes.
Of prostate cancer, from what we spent maybe a lot of time discussing, those patients on active surveillance, kind of low grade. What you described is a situation where we are pretty certain that the patients would need treatment. Those are potentially lethal cancers. So essentially any patient who has, unless they have some really horrible comorbidities that prevent them from treatment, they should be treated for that. So typically for those kind of cancers, we really look carefully to see if the cancer has spread and even metastasized. So those would be high. We've talked, Tim mentioned about that Gleason's grading score. So patients who have the high Gleason score, like 8, 9, 10, those are high grade cancers who have high PSA. We would do scans, at least CAT scan and bone scan, just to see if the cancer has spread. We are also entering the era where we have some very interesting, intriguing new imaging modalities based on PET technology that's really becoming more and more standard to have a higher sensitivity for detection of small metastases, because that makes a big difference in patients who have metastatic disease. The treatment is primarily based on drug therapy, and particularly hormonal therapy, perhaps chemotherapy. We have less emphasis then on local therapy of the prostate itself, although as Bob mentioned, that still may play a role to some degree. So that would be certainly a very careful imaging examination of these patients. If we do not see any obvious evidence of spread, then a lot of these patients still need some form of what we call multimodality therapy. So they are potentially curable in many cases, but not with a single treatment like radiation alone or surgery alone. Frequently, the hormonal therapy would be incorporated into this, and this is where my role would be as a medical oncologist. And hormonal therapy is essentially based on the concept that prostate cancer cells are stimulated to grow by male sex hormone testosterone. It's really the main growth factor. So if you cut it off, if you shut off the production of testosterone, that puts prostate cancer cells under pressure. Some of them die or become weakened and are easier to kill by radiation, and also maybe easier to be cured by surgery in some cases. So it's kind of the concept of multimodality therapy where all of us here, frankly, on this panel really play a role in those kind of patients for the treatment.
So there's a lot of excitement around the areas of immunotherapy, immuno-oncology, harnessing your immune system to eliminate the cancer. How is that working with prostate cancer?
Yeah, very interesting question. So, I would say that it's kind of so far immunotherapy has not played a prominent role in the treatment of prostate cancer, like it does in some other malignancies like melanoma, even lung cancer, kidney, bladder cancer. And there's very interesting discussion that goes into biology, why that may be, but that probably goes beyond the scope of our time. But prostate cancers don't seem to generate a strong immune response, and it's very difficult to nudge kind of immune system to recognize prostate cancer as something foreign that needs to be destroyed. So that's been an obstacle. Certainly, it hasn't been for the lack of trying. There are multiple studies looking at that, and there are some selected success stories. So there is a commercially available product called Sipuleucel T or Provenge that is kind of a vaccine type of strategy that actually has been approved for metastatic prostate cancer 10 years ago now, so relatively long time. And it has its role, although arguably it has relatively modest effect. So it's not like what we would like to see and what we see with immunotherapy for melanoma, that you can cure metastatic disease. Here, it kind of delays the disease progression. It has a modest effect. So the long way to go, I think, with in terms of immunotherapy for prostate cancer, we are definitely actively participating in some innovative trials in that area.
Terrific. I'm looking at some of these chatted in questions. Many of them have been answered along the way. So this may be one of the key questions, and that is, you see a surgeon and the surgeon says you should have a prostatectomy. You see the radiation oncologist and the radiation oncologist says you should have radiation therapy. And your brother-in-law says, do something different.
Right.
And your wife says, don't do anything. Dr. Wilson, how do you decide?
Right. Well, I think a lot of men are in that, reach that point where they're in that quandary. So I think, again, what we try to do is tailor the treatment to the individual, what makes sense for them. But so, for instance, with the simple question, in a sense, surgery versus radiation. If we think that someone has cancer on both sides of the prostate, it's not a candidate for focal therapy or like a lumpectomy that Dr. Linehan was talking about with HIFU, then many men will make up their mind by kind of whatever they're comfortable with. So, for instance, some men are surgically oriented, and they just feel better if their prostate's out. Whereas other men, want to keep their prostate no matter what. And so in some ways, it's a blessing that we have two options for whole gland treatment. For, you can, if you're more surgically oriented, then taking out the prostate's a reasonable thing to do. We can do it safely with minimal complications, men recover, and there's advantages and disadvantages. Whereas if they don't want to have the prostate out, then as Dr. Wollman has nicely described, many options of different kinds of radiation that can be used also to be tailored to the patient. We do know now, as Dr. Linehan has pointed out, that if men have cancer just in one spot on the prostate, although there's not great long-term data, but although it's mounting, that it's not unreasonable in certain select men to try what's referred to as focal therapy, or just ablating, burning, heating, like with HIFU, or even freezing a certain part of the prostate. So if that makes sense. Other factors would also include, as Dr. Wollman alluded to at the beginning of our discussion, what their urinary symptoms are. If somebody has a really big prostate, they're getting up a lot at night, a lot of times at night to urinate, for instance, they have a really slow stream, then I personally believe that surgery is a better option, because those men will actually urinate better once they've healed up from their prostatectomy. So things like that can help us decide, or help men make a decision about what to do, kind of a common sense decision about what makes sense for them.
So I imagine that in some cases, Dr. Wilson, one modality is tried, the cancer recurs or progresses, and you have to try another modality. For instance, for surgery, is it more difficult if the patient has received radiation therapy first?
It is more difficult with a higher complication rate if someone's had radiation or HIFU or cryosurgery beforehand. I do those kinds of prostatectomies. We do them robotically, and they can be done safely. What happens is that with any kind of ablative therapy, whether it be radiation or HIFU cryosurgery, it causes some inflammation around the prostate. It'll cause some scarring around the prostate. It makes subsequent surgery more difficult and healing more difficult. It's not that we can't do the surgery, but the recovery is more difficult.
Dr. Wollman, is radiation therapy after a patient's had a prostatectomy, if a tumor regrowth is seen, is radiation therapy as a second line of treatment more difficult or more prone to be associated with complications?
So what we call the salvage radiation therapy means that somebody's gone through a prostatectomy and they weren't, their cancer was not eradicated. It's not particularly more difficult. It's a little bit shorter amount of time than standard radiation, if you will. It's somewhat of a lower dose because you're not trying to kill a largish tumor in the prostate. You're just trying to mop up a few cells. So it doesn't take as much radiation to do that. Usually patients tolerate it very, very well. It can have, if they've gotten through their prostatectomy and they haven't had erectile dysfunction, it can affect their potency. But mostly they just have a little bit of brief period for a couple of weeks of urinating more frequently and feeling a little bit tired. So it's not all that difficult to do it. We don't like to do it. We like the first treatment we try to work, but when it doesn't, we do have backup options.
Well, one more question before I hand it back to Mary. I'll ask Dr. T. What's the most exciting intervention therapy that's on the horizon for prostate cancer? In 10 years, where are we going to be with this? What will have cured it?
Still, it's really so hard to go that far 10 years ahead. I think I would probably be wrong. I've been wrong predicting the future in cancer medicine, but if I were to guess and speculate, I still would put my bets, despite what I said before, I would still put my bets on immunotherapy, that we will be able to figure out how to make the immune system recognize prostate cancer as something foreign and attack it effectively. I think that's probably going to happen. To what degree, whether that will be enough, for curative effect in 10-year time frame, I don't know. In the shorter term, maybe even 1 to 5 year perspective, I think the probably the most exciting drugs are from the category of actually radiopharmaceuticals. So it's kind of the combination of targeted therapy that brings the radioactive molecule to the surface of prostate cancer cells, and it's kind of a certainly along the lines of various modes of radiation, you can say, but it's a systemic radiation approach where radioactive molecule, as I said, is kind of brought by the targeting molecule to the cancer cell, and it emits local radiation. That's really on the horizon in the near future, very promising. And then some drugs that are based on specific genetic characteristics of the cancer cells are also making headway. But in the 10-year perspective, I would still bet on a new generation of immunotherapeutics.
Very good, thank you. Well, listen, I want to thank all of the panelists for some great information on a very complex problem, and one that has more options now and better options now than ever before. I'd like to hand it back to Mary at this point, but again, thanks to all of you for your participation, and thanks for the questions that were sent in by the audience.
Thank you, Dr. Martin. I think we could have gone on for another hour. There's so much information to cover, but what an amazing panel of experts. Thank you for sharing your time, and thank all of you who attended our webinar today. The surgical techniques and research advances that you've learned about today are providing personalized treatments and are improving our patients' outcomes. Many of these leading edge advances are made possible by funding from grateful patients whose generosity truly raises the bar of healthcare at St. John's, and we're most grateful for this support. Thank you, Dr. Martin, for moderating today's webinar, and many thanks to our brilliant and inspiring physicians for sharing their expertise and vision. I think you all can clearly see how incredibly blessed St. John's is to have this amazing group of physicians leading the way in prostate cancer and urology. We hope you'll join us for future webinars, August 24th, melanoma and cutaneous skin cancer updates, and on September 28th, bone health during cancer treatment and the importance of vitamin D. So thank you all. We hope this was inspiring and we hope you learned a lot. Bye-bye now.